So I have the pleasure and honor of introducing our keynote speaker, Dr. Kenneth W. Kizer. He's the director of the Institute for Population Health Improvement, UC Davis Health System, and a distinguished professor in the UC Davis School of Medicine, Department of Emergency Medicine, and the Betty Irene Moore School of Nursing. Dr. Kizer's professional experience includes positions in both public and private sectors, and his accomplishments have been recognized with dozens of awards, and you really do have to go to his bio to look at it. It is quite distinguished, impressive. He's been selected also as one of the 100 most powerful people in healthcare by Modern Healthcare magazine on several occasions, and his work has been featured in numerous magazines and newspapers and actually national television shows as well. So please help me give a warm welcome to Dr. Kizer.
I was asked to talk this morning about healthcare consumerism and health information technology, but wasn't given much guidance about what that should entail or what I should include in my comments, which is always a dangerous thing to do. But I want to spend the time basically doing three things. I want to introduce you to the Institute for Population Health Improvement, a relatively new entity in California. And I won't spend long doing that, but just wanted to highlight some of the things that we're doing, and particularly our footprint or presence in the health IT space and where we hope to go with some of the projects that we're doing in that regard. I want to then move and talk a little bit about the California Health Equality Program, which is, as I'll go into in a little bit more depth, the effort to implement and expand the implementation of health information exchange in California. And in doing that, I want to give you a little bit of information that is literally hot off the wire. And third, and perhaps most relevant to what I was asked to talk about, is to provide a context and a construct, perhaps, for how we might think about healthcare consumerism and HIT, and indeed may help understand why HIT hasn't had the same effect on consumers in the health space as it has had in other areas. Let me tell you a little bit about the Institute for Population Health Improvement. It's a new entity that's just about 2 years old. It was, I suppose, the way that the UC Davis folks thought they could entice me back into academia, which when I left it about 20 years ago, I did not expect to appear in my future again. But it worked, and I lost my head and am now back there. And it's actually, it's been great. Since the Institute was founded, as I say, just about 2 years ago, it really didn't get going until a little less than that, 2 years ago. But we've been fairly busy. We've developed a fairly diverse portfolio of projects that now exceed $70 million. And these cover a fairly wide range of activities. In talking about population health, I suspect I should remind everyone what that is. It's a term that is bantered about widely today, without often clarity about what exactly it means. I take it to mean that it's really the intersection of clinical sciences, or the clinical sciences, and public health, and where those come together. The new value-based healthcare payment strategies that are currently being rolled out, whether it's accountable care organizations or bundled payment, which I would opine are merely steps on the way to a global payment system or a global budgeting system. And as painful as many people find that prospect, I think if you look at the numbers, or as President Clinton says, do the arithmetic, it's inevitable. And it's really a matter of when, and you may have seen the recent physician payment commission report that came out, I don't know, 3 weeks ago or so, which said basically fee-for-service should be phased out and should not exist anymore in 5 years. Whether that's aspirational or reality remains to be seen, although I think it's probably closer to the truth as we come to grips with the very real budget problems that the nation faces. But in any case, population health management should be viewed as a core competency for any healthcare system that wishes to survive, let alone prosper in the future. It's just one of those things that we have to get. And most healthcare systems would not at the moment qualify as being competent in population health management for a host of reasons. The areas where the Institute for Population Health Improvement has focused on so far, and I expect will continue to focus on, are basically in 5 areas: in healthcare reform and being a resource for healthcare reform, in clinical quality improvement, in building health leadership capacity, again, something that is desperately needed as we chart the path forward as more healthcare leaders. The 4th area is just developing clinical intelligence. We are very much focused on analytics and where that may take us. We haven't matured our portfolio as much as I'd like to, but again, this is an essentiality going forward. And then finally, we are involved in health policy in various ways. We have particularly, I think, been helpful and have established strong relationships with the state of California and a number of the health-related agencies in state government. We have a lesser footprint to date in local and federal government, but I expect that will enlarge over time as well. If we really want to focus on improving population health, we have to think much more broadly than healthcare. The studies that have been done in this regard would suggest that healthcare per se probably only has about a 10% or 15%, somewhere in that range, effect on population health, and things like having an education and meaningful work and a clean environment are much more important actually in the big picture of what makes a population healthy. Indeed, the single most important thing that we as a state or we as a nation could do to improve population health is to increase the number of college graduates. Has nothing to do with healthcare, but people who have graduated from college have many more opportunities and are much better prepared to take care of their health. A quick view of some of the things that the Institute is involved in. We are working closely with the Medi-Cal program. That's California's $60 billion a year insurance program for the poor. And I should remind you that Medi-Cal is the state's largest insurance program. Currently has over 8 million enrollees, to use a more commercial insurance term, and within 2 years we'll probably have closer to 11 million and perhaps exceeding that. It is a rapidly growing program. We are working with them in trying to improve the quality and how they track quality and reward quality. We are doing an evaluation and working with them on a program that you may not have heard of, the Delivery System Reform Incentive Payments Program, which is a part of the 1115 Medicaid waiver and means that about $3.3 billion are coming into California to the 17 counties that have designated public hospitals, certainly including Los Angeles. Indeed, Los Angeles is the only county among those 17 that has more than one facility. So that's a big deal. That similar programs are currently being rolled out in multiple other states. I will be down in Texas on Friday, working with them or talking with them about what they're doing in this regard. In New York, others are on a similar trajectory. We also are working with Department of Healthcare Services on the dual eligibles project, the Medicaid, Medicare pilot or demonstration program that's being implemented in California, hopefully very soon. The start date has been delayed multiple times, but it should start within the next few months. And this is an example of kind of one of our themes at the Institute is how do we integrate some of our programs? I'm getting ahead of myself a little bit, but the duals is a perfect example of where HIE is designed for it. Unfortunately, the timelines for implementation of the programs don't look like they will jibe so that we can integrate HIE and what we're doing in the CHECK program or the California Health Equality Program, but there's a great opportunity there. We manage the operations of the California Cancer Registry. As you may know, this is the largest population-based cancer registry in the world. It's somewhat ironic that we are now managing it insofar as I played a key role in getting the legislation to require reporting of cancer, making cancer a reportable disease when I was Director of Health for the state back in the 1980s, and then implemented the initial statewide cancer reporting system or cancer registry in 1988. We provide technical assistance to a variety of public health or chronic disease prevention and surveillance programs. I mentioned CHECK, and I'll come back to that in a moment. We are currently doing an assessment of surgical adverse events throughout the state. We have just finished a project looking at community paramedicine, a term you may not be familiar with, but it's the notion that paramedics may well be able to utilize their skills in settings other than the traditional emergency venues where they have historically practiced. There are a number of statutory and regulatory impediments to doing that, but part of that was to flesh those out. We have some research projects underway. We finally, just in this partial list, we are working with the California Health and Human Services Agency in the payment reform project. We're currently engaged in a 6-month assessment with the expectation that after that a plan will be forthcoming, which should result in a quite large, hopefully anyway, award to the state to actually implement new payment models in California, which is one way of getting people's attention, I suppose. So let me shift gears. I want to quickly go through a few things about the California Health Equality Program, or CHECK as we call it. Scott Chrisman, who is the program manager for that, is sitting in the room here, so if anyone is unhappy with CHECK or has any questions, I want to make sure you know where he's sitting. The CHECK was established last September, so it's only been around for 8 months or so. We took over, although that may not be the right word, kind of where Cali Connect left off, and have continued that and done a number of new things along the way. We administer, or CHECK is the entity within IPHI that administers the California HIE strategic and operational plan that is officially promulgated by the Health and Human Services Agency, which is how the state gets money from ONC. One of the areas where we particularly are trying to focus, and perhaps taking a little bit different direction than what has occurred in the past, is how we can use HIE as a tool to really better coordinate care, better integrate care, improve health outcomes, and think a little bit more about how HIE is a tool, not HIE itself, but merely how it can be used. And that's why I mentioned like the California Coordinated Care Initiative, the Duals Project, and how those types of things. And just to remind you of some of the key players here, the agency, I still think of it as agency from 25 or so years ago when I was working at state government. But the California Health and Human Services Agency is actually the recipient of the funds. It's delegated to, or within the agency, the Cal OHI program, which I know many of you are familiar with. And Pam Lane, who is the Deputy Director of the agency and oversees that program, will be here talking at lunchtime. And so I'm going to make my comments about this relatively brief. And then IPHI, we're implementing it, and of course the real action, the real work is done at the regional or enterprise level with the health information organizations. Our goals are pretty straightforward, and this is pretty much what we've articulated from the beginning. We really want to focus on how HIE can improve health outcomes and the integration of care, how it can improve clinical integration, among other things. We are mindful of the fact that the grant has a short timeline, and at the moment we are expecting that all funds have to be expended by the end of the current year, maybe as far as January, February into the next year, unless something changes. That's basically the timeline, which we are hoping to be able to demonstrate a measurable impact that does help lay a foundation for making HIE more sustainable going forward. We're working a lot in trying to create a trust environment for clinicians, and I think Pam will say some things particularly about that at noon. And then, as I've mentioned already, how do we integrate HIE into other programs? Just to give you a depiction of how this money, the grant that we ultimately was able to finagle out of the Health and Human Services Agency was $16.6 million. They retained portion of what was left over when the baton was passed from Cal Connect to CHEC. But it falls into a number of buckets, as you can see. Some of these have already been funded and are underway, and I'm not going to take the time to go through what's in each of these, and they've probably covered already much of what I wanted to say about our strategy. Although, again, I want to make sure that you are aware of the work that California is doing with the Western States Consortium in promoting exchange of information across state lines, and the fact that this is actually moving along very rapidly. We're exchanging information with Oregon, Alaska has joined, there are other states in the wings. And I perhaps should also just show this map which illustrates the number and the amount of HIE activity that's going on in California. It's a lot. And one of the ongoing issues that we have with the federal government is that most states have a statewide HIE. And in their mind, well, why don't you have one HIE and everyone will participate and, make it a lot simpler. Those are largely for people who've never been to California and certainly don't understand the nuances between Southern California and Northern California, and between San Francisco and inland Northern. I mean, well, it's just a very different environment, and the approach that's being taken in most states simply is a non-starter from the get-go here in California. I do want to just say a little bit about the HIE Acceleration Grants, which is one of those buckets that I showed before. And several things have happened there in the last 3 months or so. The infrastructure interface awards were awarded, and after a few contractual difficulties with getting the contracts out of the university, which unfortunately I have little ability to influence, they are now all out, and all of our contractors are, I think, breathing a little bit easier than they were a couple of weeks ago. We also, I want to emphasize or just highlight a couple of other awards that were posted just last week or as recently as yesterday, and these are in the rural program. the Rural HIE Incentive Program, which is intended to help catalyze the uptake of HIE in what are historically underserved areas and where there may not be the same incentives for HIE to develop as may exist in more urban areas. And also the Data Analytics Awards, which were made last week, and I'll come back to in a moment. But the rural programs, I would not expect many people looked at our website yesterday when these were posted, but 5 awards were made to what we're calling designated rural HIE providers, and their services that they provide include directed exchange, or using direct, as well as other more query-based exchange and some others, and you can see that. Those, the intent of this is really to try to subsidize the users so that it is economically viable to establish HIE, which at some point will, hopefully it will make its financial case and will be sustainable, but getting over that initial hurdle is too much for some of these areas, and that's what this is all about. The 5 awardees, and I suspect that, as a matter of fact, I know some of them are here today. Hopefully they've all gotten notice, I'm sure they have, but are as listed here: the Informatics Corporation of America, Redwood MedNet, Accession, Inland Empire, and then Ocprio. Those are the 5 entities, and divided according to the types of exchange services they'll be providing, that will be working with us over the next several months to hopefully catalyze the uptake of HIE in rural areas. The analytics program, the 2 awards there to Inland Empire Health Information Exchange and Tahoe Forest Hospital District were posted last week. Those are for lesser amounts, but the intent there is try to help, again, these programs develop population health-based programs and to help in the analytic process and other things that may not be otherwise possible. The last thing I would note here, we have a couple of other grant programs that will be forthcoming within the next couple of months. The one that probably has the most to do with healthcare consumerism is the Blue Button initiative, which is a new addition to the program, and again, I suspect everyone is familiar with the Blue Button initiative, but we hope to partner with at least one and hopefully 2 Medi-Cal managed care programs to implement the Blue Button in their populations. This will be the first attempt in the nation to implement Blue Button in a Medicaid population, and so we're not entirely sure what to expect, but we're optimistic that it will start actually a trend and will facilitate others adopting Blue Button going forward. So let me shift gears. I've probably spent more time than I should have on these 2 things. And try to provide some context or perhaps a construct for how we might think about HIT, not just HIE, but healthcare information technology broadly, and healthcare consumerism. And I should just remind us, what's the problem and what's driving all of the effort for healthcare reform. And I could give you very complicated charts and tables and lists, but it really boils down to a few things. Healthcare costs in America are rising rapidly and are unsustainable. It is, we currently spend 2 to 3 times more per person on healthcare than any other industrialized nation, and yet the results we get are not as good. And that's been now well documented. The thing that causes heartburn, though, when you look at what's driving healthcare costs and I didn't include it here, but if you look at the 10 things that are driving healthcare costs to rise so disproportionately, there's actually very little that can be done to bend that curve in the short term. So we are currently at 18% of GNP on healthcare. We will hit 20%. I will not be surprised if we hit 22% or something higher. And of course, we always have to understand that these come out of discretionary spending, most of it from the federal government, and the amount of funds that are available, or most of this comes out of the mandatory pot at present, which as that grows, it means the discretionary pot is shrinking. And in the last 40 years, those relative proportions have exactly switched. So that now about 2/3 of the federal budget is in mandatory programs, mostly Medicare and Social Security, and Medicaid being a significant component as well, with all the discretionary spending being in the other third, and about half, actually more than half of that is consumed by defense and national security, which means that everything else we want as a nation, highways, schools, parks, go down the list, all have to come out of a diminishing proportion of the federal budget, which is now around 16 or 17%. And the demands, for example, in infrastructure, in highways and bridges and stuff, is accelerating or is rapidly rising. So we have some real difficult financial issues, and really the only way out of it is to diminish in one way or another the relative amount that's being spent on healthcare. And of course, that's what much of the debate is about. The second driver is just performance deficiencies. You know, for all the money we spend on healthcare, we're not getting all that great of a product. And again, well documented, from medical errors to poor quality, and you can go down the list. Don't need to belabor that. And because we have a relatively unique situation in the U.S. where employers pay for so much of healthcare, which is, as you may well know, an artifact of World War II, when price controls were put in effect for a period of time. So employers could not offer increased wages to their employees. So what they did was start increasing the benefits, and healthcare being one of those benefits. But that is really why, unlike most of the rest of the world, where healthcare is much more of a government responsibility, in the U.S. it has remained largely a private sector activity. But without going into all those details, since employers are paying so much of the bill and they're unhappy, they have been, or what I've called purchaser activism, has been a major driver in healthcare reform, which is somewhat unfortunate, as it's not being driven by healthcare, but it's driven by the payers, which creates some perverse dynamics in and of itself. Consumers have changing tastes, changing perspectives. They want basically a different product than what healthcare is providing them today. And so the focus of this meeting about healthcare consumerism really is one of the 5 major forces that are driving healthcare reform broadly. The last, and perhaps the one that has gotten insufficient attention, at least in my mind, is the fact that population health, the overall health of the American population, has not only stagnated, but is diminishing in a number of areas. Which, if we chart this out, and indeed the IOM, Institute of Medicine, did a very nice job recently in their report, which looked at the health, not health care, but the health of the American public compared to other developed countries. And in just about every category, we came in at the bottom, or next to the bottom. The 17 countries, we were consistently at 16 or 17, notwithstanding the fact that we're spending 2 to 3 times as much on healthcare as these other countries. Clearly, something is wrong with that picture. Indeed, I would posit that as important as the budget deficit is, which has to get resolved, the health deficit that is confronting America is a more insidious and far more threatening concern to the long-term well-being of this nation. Indeed, it is a national security issue. if 75, as is the case, 75% of people who try to enlist in the Army, which has the least rigorous requirements of any of the services, cannot pass those requirements, and they are rejected, largely for health reasons, but also for lack of education or criminal activity. That doesn't portend well in the unfriendly world that we live in today. So, is the Affordable Care Act, is that the solution to all these problems? No. It is a major milestone on the path, but there's more to come. And people who are fatigued in thinking about health care reform and all that the ACA has brought need to tighten their seatbelt and stand by, because the waters are going to continue to be turbulent, and probably more turbulent as we move forward. And despite one's politics, there really are very few options as to what has to happen, and most of them are embedded in the Affordable Care Act in one way or another. It is a political instrument, so it may not be perfect, but most of the problems that are surfacing are things that are fixable. Now, in thinking about where we go in healthcare reform, I think we need to remind ourselves that healthcare operates as a complex adaptive system. And that has particular implications for how one goes about trying to change it. And I'm mindful that from the purists of complexity theory might take exception with some of what I'm going to say, but it's close enough that I think it works for our purposes. And we need to remind ourselves that complex adaptive systems operate by a different set of rules than the more traditional linear manufacturing models. And indeed, that may be one of the reasons why an awful lot of health policy, which is predicated on those linear manufacturing models, isn't very helpful, and in some cases has been actually less than helpful. But in complex adaptive systems, they aren't linear. They're dynamic. They don't reach fixed equilibrium points. They're continually changing, because they have independent agents who are intelligent. They learn, they modify their behavior according to changing circumstances, and their goals and behaviors aren't all aligned. And all you have to do is think about doctors, hospitals, nurses, pharmacists, and the other agents in healthcare, and it becomes pretty obvious that they have different goals and different needs and different aspirations as to how they think the system should operate. Perhaps even more important is the observation that in complex adaptive systems, no one is actually in charge. I mean, we can delude ourselves into thinking that someone actually is in charge, but the system is in charge, and the forces that are driving it. And there is no one single point of control, as there may be, again, in more linear processes. So that means that how you go about changing a complex adaptive system is fundamentally different than how you may go about changing other systems. And it means, or how this translates, is that basically when one wants to change a complex adaptive system, you have to find those few key change levers. Those critical elements that if you tweak them a little bit, the effects get magnified and ramify throughout the system and produce much larger systemic change. So the question that you can ask is, so what are healthcare's critical change levers? And again, it's a small number. I think there are really 5 that are at the heart of everything that's being done or could be done to drive healthcare, and the most important, of course, is financing. Payment, dollars, it's a universal elixir. And what we do with that has profound implications, as we are seeing as with some of the new value-based purchasing strategies. Performance measurement is certainly another one of those key levers, and again, we're seeing fairly dramatic changes as doctors and hospitals and others are having to put their performance out there. And this shouldn't be surprising for anyone who's been involved in healthcare. I mean, the people who, in high school and college, we all worked for the grade. It was all about where you were on the curve, and so, performance was critical. It's kind of almost in the DNA of healthcare. So performance measurement and reporting those results tends to have a powerful effect, much more powerful than may be associated with the dollars that's associated with that, as we can see with the Premier example and others. Health information technology, I would put there as a driver, largely because it allows us to think about the processes of care in completely different ways. I think the hospitals or physician offices, clinics that have utilized electronic health records just to automate their existing lousy and dysfunctional processes tend not to be enthralled with EHRs, because then you just get automated lousy processes, which tend to be harder to fix than the manual ones. The real value and the promise of HIT is that it allows us to fundamentally rethink healthcare, rethink those processes, and perhaps nowhere it's just played out more than in the area of consumerism and what we could do to drive consumer behavior, which is the fourth driver. And then the last on this short list is simply either regulation or in some cases regulatory relief, as was seen when the Stark rules were relaxed that allowed hospitals and physicians to work together in some new ways in implementing electronic health records. And there are other examples where regulatory relief may be as important as allowing people to do things, may be as important as saying what you can't do. One of the other basic tenets of how you use these change levers to affect change in a complex adaptive system, though, is that they have to be aligned and ideally are mutually reinforcing, which gets at one of the problems that we have currently, is that these change levers aren't necessarily as well aligned as they should be. And we could cite many examples, but payment for HIT in thinking about telehealth or mHealth or other modalities that might well be very useful, but currently they're not part of the payment equation by and large. And so those aren't aligned, and not surprisingly, you're not seeing the uptake in some cases or the potential benefit being realized simply because of that. So, the question is information technology empowering healthcare consumers to change healthcare the way it has empowered consumers in other areas? And I think it's a mixed picture and not as encouraging or as gratifying as one might like. This paper actually was published 2 days ago, so hot off the press. But this is one example where it has using electronic media has actually encouraged people to change lifestyles. It's I think, the sort of thing that's very encouraging. We can look at some other recent publications which paint a less favorable impression. I mean, lots of activity in this regard, but when you actually sit down and do a careful evaluation and a systemic analysis of the data, it shows that the results are not so good. I mean, there's some positive stuff here, but it's not as dramatic as one might hope, and as, in fact, we need to see if we're going to see it really change and be a driving force the way that I think many of us would like to see it. Yes, the results are encouraging. They hold promise, but I would posit they really haven't been as dramatic as they need to be if we're going to really use this as a lever to change an enterprise as large and complex as healthcare. So one of the questions that always comes up, what is healthcare consumerism? And certainly as one who lives in the academic world, I'm all for finding big words that describe simple concepts because it may help get grants or make you look smart or do other sorts of things. And the words that are often used to describe healthcare consumerism, patient-centeredness. I can point to at least 6 different examples of how patient-centeredness is defined. So it's clear that there's not clarity about what exactly that means. patient empowerment, patient engagement, patient autonomy. These all are, they sound good if you can figure out what they mean. And once you figure out what they mean, how do you actually operationalize it and turn it into something that you can do? So I would posit that a simpler and perhaps more usable construct for thinking about consumerism are the 5 C's. And I know if you count the words, there are 7, but I only have 5 fingers. So, it goes back to what drives consumer behavior in any area. And first, and at the top of this list, is choice. The corollary to that is control, because if you have choice, you then can control what is done to you or for you, et cetera. And indeed, if we look at American culture, this is the one or the highest value or the highest trait, quality, whatever the right term is, that American culture places extremely high value on choice. Now, one might say, well, freedom is there. Well, what does freedom do? Freedom gives you choice. So this is embedded into our culture. So the first C on consumerism is simply choice. The second is convenience. We don't have to look far. Actually, when I drove in here, I didn't see a McDonald's or a Burger King, but I suspect if I drive a block or so, I'll find one. Fast food industry, others have certainly understood the importance of convenience. Collaboration is another key element here, and the corollary there is connected. Patients want to, today, have collaborative relationships with their caregivers. They also want to be connected to other people who have their condition, who are sharing their life experience, who may be going through the same challenges that they are. I could put commiserate probably as another one, because people like to commiserate, but it didn't quite fit. But collaboration is really much of what this is about. Comfort. People don't want to be in pain, a la, pain is the 5th vital sign, other things that are being done in that regard. But if you are, a senior, which is increasingly getting older as I get older. But if you're 70, 75, have 3 or 4 or 5 chronic conditions, getting in to see your caregiver and sitting in those hard plastic chairs in the waiting room with 30 other people crammed in with you, it's just not comfortable. And there are lots of other examples where we get cited. So people are looking for comfort in many different ways. And last on the list of 5 C's is cost. And it's last because it's the one that most people are shielded from the most. Insurance, other payers, and cost still hasn't entered the consciousness of most healthcare consumers the way that it has for other sectors or other enterprises. Now that is going to change. It will change probably incrementally, but it is still not trivial, and so it certainly is on those lists. Now, I'm reminded, if you want one great example, and among many, of folks who were leaders in their industry, and within a few years were going bankrupt. Borders is a poster child. And largely because IT changed buying habits, what consumers wanted, and not to name names, but there are other entities who figured this out and are putting major strain on this whole industry because they understand what consumerism is all about. And perhaps, and I'm mindful of the clock, if we were to think about how we might truly empower healthcare consumers to make them truly at the center of the healthcare universe, we might think about IT as doing a number of things. Certainly, its value is in providing data. Unfortunately, much of the data isn't particularly useful. and in some cases it's unreliable or dangerous. So when we think about the data, it has to be actionable, which usually means it has to be fairly granular. You know, the quality metrics are a good example of an effort to make information available about your caregiver. And I applaud the effort. And if you happen to have congestive heart failure or asthma or diabetes, it's probably useful. But if you have peptic ulcer disease or multiple sclerosis or any number of other relatively common conditions, how your provider does in treating congestive heart failure isn't particularly useful. It's not meaningful, it's not actionable. So as we go down this path, the information has to get more and more granular, and so that it has actual meaning to the person who's looking at it. And I can share perhaps one short example of a conversation I had yesterday with one of my staff who, when he moved to California, needed to find a new doctor. And so in the area, he found out who was in his insurance plan, went to the phone book, did some other things, finally decided on a provider or a physician who kind of was the same as all the others on their quality metrics, so that wasn't terribly helpful. And he decided, because this provider was a mile away, as opposed to the next one being 5 miles away, he went with the first one. You know, all this information wasn't terribly helpful. But I asked him, you know, what would have changed your mind to go to the one that was 5 miles away, or maybe even further, as opposed to the one that just happened to be geographically closest to you, which meant you had to spend the least amount of time in your car getting there. And it was things like, well, do they use email to communicate with patients? Do they have e-rounds? Do they use texting? Do they use telehealth so that, heaven forbid, I wanted to get seen in my home using a telehealth connection, I could actually do that. I went down the list of a number of IT tools that potentially could have been available, but none of that information was available. I would posit that in the future, and probably not too far in the future, those sorts of things are going to start differentiating providers, because they allow one to actually operationalize these concepts of consumerism. Now, in that regard, if you focus on the 5 C's, if you hit 3 of them, you pretty much have a winner, a guaranteed winner. Certainly, you got to hit at least 2 if you're going to have significant uptake. But the more of those that one can hit with their tool, the more likely it will be to be utilized widely, to uptake and really change behavior. And then the last point I would make is simply that these tools and these efforts in consumer have to be aligned with others. As I mentioned already, our payment policies are perhaps one of the bigger barriers to operationalizing a lot of the potential HIE tools, because they simply don't factor into how providers get paid or what that might mean to the consumer as far as their cost. There are other ways as well, but in the interest of time, I think I will stop here. I thank you for your attentiveness, and I thank the HIMSS for the opportunity to be here today, and I look forward to hearing the rest of the conference. Thank you.